Welcome everyone on board. We just started our discussion on some basic concepts and some main points about some topics related to ICU. So we will continue our from where we stopped that day. So actually, like ICU questions when they ask is sometimes sorry, just give me a second. Okay. So sometimes these questions are related to management of a number of conditions ICU. Okay. So I will just Hassam, I will start from you that a burn patient, what do you think? What could be the considerations of a burn patient? ICU?
Sir, sir, will
First of all,
depend on
how will you evaluate a patient who had a burn?
sir. Sir, sir, I will evaluate this patient on the basis of history and examination. In history, it will be important that what kind of burns he has. It is electrical burn, it is a scald burn, or it is a pure thermal burn, and
Okay.
how much area it has involved, and what time has it occurred, and are there any association with inhalational injuries?
Okay.
My important concerns will be, sir, regarding fluid resuscitation, to take good IV lines. Rather, I will approach this patient with airway
Will
breathing
IV line
circulation approach.
will IV line be easy in patient with extensive burn?
No, sir, it will be difficult. And secondly, if as the time passes and swelling is taking place, it becomes more difficult.
Okay.
Secondly, sir, I will pick up the signs rather before fluid resuscitation. I'll pick up the signs for any sort of inhalational injury or any
Mhm.
evidence of carbonaceous sputum or hoarseness or stridor or nasal singed hairs, in which I'll be proactively intubating this patient, as airway edema will further deteriorate it.
Okay.
Uh,
Okay. So
Thirdly, sir,
so
I would like to give good antibiotic cover. I will prevent this patient from hypothermia. I'll give
okay.
this patient stress ulcer prophylaxis.
Okay. Okay. What will be the concern if you are managing such patients airway who have suspected uh, like airway involvement?
Sir, sir, these patients generally develop airway edema very rapidly. So I will anticipate a difficult airway. Secondly, sir, in initial, if I'm receiving the patient in first 12 to 24 hours, I can safely use succinylcholine. After that, succinylcholine can cause hyperkalemia, so I will avoid it.
Okay.
Thirdly, sir, it will be a difficult airway, but and I will prefer to do pre-oxygenation with difficult airway trolley ready and do RSI.
Okay. So when you are inducing such patient, do you
Sir,
expect something? Like, is there any care would you
uh,
like to do?
s- sir, I would be expecting hemodynamic collapse in this
Very good.
patient. So I will
Very good.
try to do good fluid resuscitation and give titrated doses of uh, opioid along with the main induction agent.
Okay. So, for example, if you have a 45% burn with the involvement of chest abdomen as well. Okay. So, first of all, how much fluid would you like to give?
Sir, I would like to give
Uh,
crystalloid,
patient is
preferably
70 kg. 70 kg adult.
Sir, sir. Sir, I will give him fluid. I will resuscitate him with the ringer lactate as per Parkland formula, which is 4 ml multiplied by 70 multiplied by 45. So the amount I will give half in first 8 hours and half in next 16 hours.
Okay. So, like, what are the concern if you want to use colloids? Can you use
Uh,
colloids
s-
in first 24
sir,
hours?
sir, in initial phase there is fluid creeping, so there will be colloids won't stay intravascular, so there would be no benefit of giving colloid in first 24 hours.
Okay. So, other than, so up till now, we discussed that what are other concern other than airway and fluid? Is there anything very important you are missing? You have not mentioned at all. That's a
Sir,
very
Urine
important.
hypothermia,
catheterization.
I'm sorry.
hypothermia, sir, risk of hypothermia.
Foliage catheterization for urine estimation.
Just a second. Just I will. Who's speaking? Can you just raise your hand? I will ask you. I will give you a time. Just give me a minute. Dr. Aslam, I will just give you a chance. Just give. Uh, you are missing something. Not urine output will be there in any patient. Okay. This is for fluid
Sir,
balance.
sir, antibiotic
Please,
prophylaxis.
antibiotic you have already told. You are missing something very important, which is there. It's a big concern actually. You told about IV, you told about airway, you told about succinylcholine, you told about area of burn, etc., etc., etc. You are missing something very important.
Analgesia, sir.
Very good. Okay. So analgesia is a big problem, especially if it is like initial part, it's a very painful situation. Okay. So in addition to all everything, you should be telling whenever you are telling answering this question, you should be telling analgesia about analgesia some, or you say that it's a painful condition. Okay.
Sir.
So um, okay. So what else need to be known, because actually there are a number of formulas with reference to burn. Okay, so they can ask you a few of the formulas, and like they can ask you about another thing, with like, because they can ask burn as a part of polytrauma. Okay, you can say blast injury. So if they are asking you this question, in addition to what you have told, there may be, like, you can say you will combine ATLS, because in this there may be multiple uh, things involved. Okay.
Yes, sir.
Okay, so you mentioned about IV lines. So how like what will be different ways to manage to solve this problem?
Sir. Sir, number one, as soon as possible the patient arrives, I would like to put on IV lines. As the time passes, swelling will take place.
Mhm.
So initially, sir, if veins are accessible with line technique, then normally we use. Secondly, sir, we can use ultrasound guided lines.
Okay.
Thirdly, central lines.
Interventional radiology, like interventional radiology for maybe like one of places where it may be used, or venesection, surgical venesection. Okay. Would vein visualizer will help here?
Yes, sir.
Okay. So you can say another important point you have not mentioned, monitoring. Monitoring will also be challenging. Okay. So what will be the problems in monitoring? Okay, first, if you just think about pulse oximetry, What can be the challenges in burn?
Sir, if their peripheries are involved or burnt, it would be difficult to place oximeter. It would be difficult to place pulse oximeter. Its
Okay.
reading will not be
Anything
there, and it would be painful.
anything else than placement?
The carbon
Carboxyhemoglobin
monoxide poison,
will not be, yes.
Yes, carboxyhemoglobin.
sir, it would
So
be difficult to differentiate between carboxyhemoglobin and hemoglobin.
okay. Um, so how would you how differentiate whether this saturation
With
100% is
co-oximetry,
co-oximetry or what else?
ABG, sir.
ABGs. And clinical features of carbon monoxide poisoning. Okay. So, okay. Dr. Aslam, are you also exam candidate for FCPS?
No, sir, I am a candidate for EDEC Part 2.
Okay. So sure, we are welcome. Actually, I would like to. So if you can say a few words. Okay,
Sir,
Hassam,
we have Dr. Talha, who is also exam candidate.
sure. So let's give chance to Dr. Aslam, and after that, Talha, I will. So what are the issues with carbon monoxide poisoning? Yes, Dr. Aslam.
Yes, sir. Carbon monoxide is 250 times more stronger affinity than the normal hemoglobin in compared to the oxygen. So it is very evidently adhered to the hemoglobin,
Mhm.
and this causes a problem with the uh, carboxyhemoglobin dissociation, and it leads to the ODC to the right side of the carbon.
ODC to the right or left?
Sorry, sir, left side of the car.
Okay,
Sorry.
so it shift to the left. This is one
Yes.
thing. And so what will happening that oxygen delivery will be hampered. Okay,
Yes.
because can you tell me the formula for oxygen delivery? How to calculate the
Yes.
oxygen content?
Sir, for the oxygen, one is the 1.34 into hemoglobin HbO2 into one into saturation plus 0.03 into SaO2. SaO2 the
Point zero zero
means
three,
the
not 03,
uh,
0.003 into PO2.
SaO2. CO2. Yes, sir.
PO2. So PO2 is this is dissolved oxygen.
Dissolved
Okay,
oxygen. Yes.
and
Yes.
this is oxygen carried by hemoglobin.
Hemoglobin.
Okay,
Yes.
so when we are treating a patient with carbon monoxide poisoning, how you actually
Yeah.
treat?
Uh, when because of the when we encounter with the carboxyhemoglobin patient who is the suffered from the burn patient, then we have to put some oxygen mask, and to reduce the amount of the time taken. So hyperbaric
It's
oxygen is another option.
no, just a second. So oxygen mask. Do you think what will be is it a correct answer? But you can use a better word that you will increase the FiO2. Okay.
FiO2, yes, sir.
So instead of 21%, you are trying to give 100%. Okay.
100%.
So it will reduce the time. So what about hyperbaric oxygen? Where hyperbaric, what is the mechanism, rationale of using hyperbaric oxygen in carbon monoxide poisoning?
When we give the in hyperbaric oxygen, we give increases the atmospheric pressure around 2 to 3 atmospheric pressure, and then we put the this amount of the hyper baric condition to the patient. This will increases the tissue perfusion, and
No, just a second. Like for example, if you come here, will it attack here or will it attack here? Like dissolve part
it will
or
increase. No, it will increase the soluble part, because HB is
yes. So
already associated with the,
you
yes,
see, it will attack here. The effect will be
Yeah.
here on PO2.
Yes.
Okay.
Yes, sir.
So usually, do you know what is posture point?
Posture point is the condition where below which the tissue, I mean to say, hypo, where should I have read, but I am unable to concentrate at this time.
Okay, I think this is the oxygen requirement at cellular level. Okay.
Yes,
So
mitochondrial level actually.
yes. So it's a very small amount. So it's a very small amount. So oxygen utilize is not that much. So it will increase the dissolved oxygen, because oxygen carried by it will carbon monoxide will vanish from the circulation it with its time. Okay. So
Yes, sir.
you will give time. In the meantime, you will try to give hyperbaric oxygen to support. Okay. Rest of the treatment will be like intubation and 100% oxygen, or like you can supportive management in the otherwise. Because, for example, if you have a patient with cardiac, okay, so now if this patient has carbon monoxide poisoning, so actually patient can have MI. Okay. So the patient can have CVA anywhere, like because of low PO2, all the problems can occur because oxygen, the tissues are not receiving the oxygen. So in addition to what you are doing, rest of the management will be according to what happened. Okay. So that's will be happening. Okay. So that's it, because rest they can ask you about thickness, about burn. Okay. So if you just consider like what you should be knowing, types of burn, how much severity of the burn, first degree, second degree, third degree. Okay. And how much you calculate the formula. What are common surgeries? They are coming actually again and again for debridements. So they can ask you with that reference, the post op, sorry, with reference to ICU, the patient will be, you will be, they can ask you about infection, they can ask you about airway management, they can ask you about fluid management, and if it is circumferential, that can create problem with the ventilation, airway pressure will be high. Okay. So another important, yes, one more thing. Now I opened the text to see. We missed about nutrition. Okay, because it's a catabolic state. So patient need a very good uh, nutritional support. Okay, so that's it. So now, Dr. Talha, next question will be from you. Are you there, Dr. Talha?
Yes, sir.
Okay. Um, okay. Okay. So you have a eclamptic patient, okay, who came
Correct.
to ICU intubated. So, like, what will be the consideration in this patient, eclamptic patient?
The eclamptic patients are usually at risk of developing seizures even after delivery of the baby up to 48 to 72 hours. So I will, my first concern will be about that seizure happening again. And before that, airway breathing circulation will be my topmost priority. After that, hemodynamic stability, along with BP management and seizure control.
So general ICU care, you can say airway, breathing, circulation, and general ICU care. Okay. And if they want to ask
Correct.
some details about that, that can explore. But you can say the general ICU care, which is there in any ventilated patient, with reference to sepsis
Sir.
prophylaxis, with reference to ARDS prophylaxis, with reference to ventilator associated pneumonia, all the lines, care of lines and everything, the general care. Okay. And then and the
Sir.
specific care with reference to patient can have another seizures. So, okay. So, like with reference to seizures, is there something you need to be considering? What will be the different ways to prevent seizures?
Sir, most likely that patient will be having infusion of MgSO4 if he is a non-eclamptic. I will
Mhm.
continue that infusion at 1 mg per 1 gram per hour for next 24 hours. And
Okay.
along
So
with that, uh,
how you
uh,
monitor if the patient is on magnesium, how you monitor that patient?
sir, for magnesium, when patient is on magnesium therapy, we try to check her reflexes every hour. And initially, we will see the loss of deep tendon reflexes if patient is getting more magnesium than required.
Okay. What else?
Sir, along with that, we can get serum magnesium levels and
Okay.
Urine output.
No, Dr. Aslam, just let him be. You can write in the chat box. Let him speak. And if anything you want, you can write in the chat box. And after I will ask anything we missed, then you can speak out. Okay. Okay. What reflexes? Serum magnesium. What else?
sir, reflexes and serum magnesium levels.
You are missing something very important. First of all, in
Uh,
intubated patient, would you like to do reflexes?
sir,
See,
no.
this is
That
an.
will be
I told
difficult
you
to.
that in the scenario that this is an ventilated patient. Okay.
Sir, sir,
So be
sir,
practical. Come out of the book. Okay. Come out of the
sir.
books. Yeah, magnesium. What about ECG?
Sir, yes, ECG monitoring, sir,
What
along with
about
all baseline monitoring and EEG if available.
EEG? Okay. Try to be very simple. Okay. They will catch you. What will be the changes?
Okay,
How will you monitor? Don't stuck your before urine output. If you are telling EEG, you are inviting trouble. Remember.
okay.
Okay. Have you ever seen anyone monitoring EEG in ICU?
No, sir.
So don't
Only
try
the
to be hero.
patient will hit.
In the exam,
Okay,
if you try to be hero, my dear, they will catch your neck. Okay. So you have not told
okay.
is urine output. What does magnesium affect urine output?
Sir, sir, I'm not sure.
Think about it. Can magnesium affect urine output, or urine output can affect magnesium level?
Sir, definitely.
It's other way around.
Sir,
Okay.
both it.
No, no.
Okay, sir.
Magnesium cannot decrease urine output. Okay. Urine output, if it is decreased, it
Oh,
can increase the magnesium levels. So that's why practically, whenever we are giving magnesium, we can do serum magnesium levels. We can monitor through ECG. Practically, this is the most important thing. If there will be arrhythmias, patient will have like if toxicity is occurring, then there will be some ECG changes. Am I right?
sir,
What
sir.
will be the effect of magnesium on hemodynamics, like blood pressure? What will be the effect if it is going toxic? Will it cause hypertension or hypotension?
Sir, hypotension.
Why?
Uh, Hypotension.
Remember, my dear, this is a
It,
message
it
for
acts
all
as
of
a
you.
vasodilator.
Yes, it's a vasodilator. Remember one thing. This is difference
Sir,
between written and viva. Please try to have the reason. Okay? Because it's not like reproducing some page number ABC of the book. You should be knowing the reason. So magnesium it cause vasodilatation. Okay, so that's why smooth muscle relaxation. That's why it's you can say it's antagonist of calcium. Okay, so that's why
okay,
it's causing vasodilated smooth muscle relaxation, and that is the reason of hyper. So if it is going overdose, it can itself it's magnesium is being used for the reflexes. Sorry for arrhythmias, but it can cause arrhythmias. Okay, magnesium is used for resistant. If nothing is working, then you can use magnesium. Am I right? So be logical.
sir.
And no, there is, try to be like, if you are saying, you can use the word standard 1, standard 2 monitoring, and then you can elaborate anything else. Okay. Like, like if the patient is having magnesium, and a clinic patient, if it is hypertensive, you can use ABGs, sorry, arterial line. You can say about arterial line, that you can have arterial line for frequent ABGs, as well as like blood pressure monitoring. Okay. And okay, I hope you understand. So what other
Yes,
complications
sir.
can occur in a patient with eclampsia?
Sir, patient
In
can be
post-op period.
hypertensive.
Okay, hypertension, fits,
The patient can be if patient can be hypovolemic and dehydrated if
hypovolemic.
volume resuscitation has not been done due to
Okay,
hypertension.
okay, okay. What
and
else?
uh, and that said, and all the complications of magnesium therapy, if
Magnesium
patient
we have
has been
already
started on
discussed.
magnesium.
Okay, what
Sir.
else?
And sir, after that, any complications that can happen in ICU, like ETT related,
You
ventilated.
are missing something. Can the what is
And
HELP syndrome?
sir, the yes, sir, health syndrome, hemolysis, elevated liver, uh,
So you have not told
enzymes, and
anything, any systemic involvement of eclampsia. It's what is
sir,
preeclampsia? What is different between preeclampsia and eclampsia?
sir, preeclamptic patient which is uh, uh, having fits, it's called eclamptic patient.
Okay, so preeclamptic patient can have this severe preeclampsia.
Uh, yes, sir.
So you did not mention anything about it.
Sir.
Okay. So because in table viva, you have 5 minutes. So in five
Okay.
minutes, you have to think and speak out, because 5 minutes will be total for all the questions and everything. So if you are not able to think and anticipate, you will miss. Okay.
Okay.
So any problems related to eclampsia, preeclampsia, HELP syndrome, and any other obstetric problem. Okay. So by the
Yes.
way, what's difference between preeclampsia and like how would you say that it is not gestational hypertension, or it's what thing make hypertension to preeclampsia?
Sir, it's the onset of the hypertension.
After
If
20
it's
weeks,
after 20th week, it's
what else?
preeclampsia
What else?
and sir, proteinuria.
Okay, proteinuria. Okay, so that's how they differentiate. Okay, so
Sir.
um, okay. So actually, this is a question which they can ask you, or I tell you something. Maybe they don't ask you this scenario, but when if they are asking you eclampsia, you can have few words when they are telling, they are asking about a eclamptic patient post-op. So you can tell these things in a summarized way. When you are if they are asking you a scenario with like a pregnant patient with blood pressure of 200 by 120 coming for cesarean section, and after that, that part we have discussed, actually the last part, which we usually nobody discuss, because this is uh, like something other aspect of eclampsia. Okay, so that will be
Okay.
the preoperative and intraoperative care will continue in postoperative care. Usually patients who have frequent fits, they may be, they consider not to extubate the patient, or if cause of eclampsia or anything, patient has bleeding or patient has like not stable, in that condition maybe you are not extubating the patient. Okay, or another thing, any signs of raised ICP. Okay, because neurological involvement can be there. So if there is any signs of raised ICP in this, that may be the possible indications of post-op ventilation, because not every patient will be uh, ventilated post-operatively. Okay, so like whenever if they are asking a scenario of eclampsia, you can continue your answer. Yes, papillary edema will be there. Raised ICP. What will be the signs of raised ICP in anesthesia? Anesthetist can pick raised ICP with which signs? Dr. Aslam, you can tell. Yes, Talha, you can tell, please. What will be the signs of raised ICP?
Sir, Cushing reflex, which is characterized by hypertension, bradycardia, and
Don't tell me abnormal
one.
respiration. In
No, sir, hypertension.
you can say that it is a Cushing triad is combination the but in during anesthesia if there is hypertension with bradycardia, okay,
Sir,
so it's a possible sign of like that ICP may be raised. Otherwise, because of course you will not monitor the ICP. So okay, if this occurs, you are so what will you do immediately? What will be the immediate what you should do immediately?
sir, for immediately, sir, position of the patient.
Okay, position.
We
Increase
will
the
put the
respiratory
patient
rate
at.
to remove the hypercarbia.
Okay, so hyperventilation. So CO2 you will try to wash out. Actually, this is the answer I would like to listen because immediate management will be you will try to wash out CO. Okay. Otherwise, there are so
Then
many
you can
things.
use the mannitol and other osmodiuretic drugs.
Actually, these mannitol or anything else come after your management. Okay. You will make sure patient is having good PO2. There is no hypoxia, there is no hypercarbia, there is no acidosis, there is no pain, there is no. So you will try to cover the reversible anesthetic factors, and then next step you will go for anything more than that. Okay. Okay. Uh, Other than Hassam, who else is exam candidate? Okay, Hassam. Next question for you. You have a COVID positive patient who was in ICU for some time, and now this patient is coming for um, this PEG tube, gastrostomy tube. Okay, so what will be your concerns in this patient?
Sir, I will firstly evaluate this patient on the basis of history. When this patient had COVID,
Your there is a lot of echo. Yes, now
sir, it
please.
was not from my side.
Yes,
Okay,
I
when this
got it.
patient had COVID, what kind of treatment he had? Was he kept in ICU for it? Was he intubated or ventilated for this?
Patient is coming from ICU
And
ventilated.
sir, when was he COVID positive?
Okay, okay, what else?
And sir, in investigation, I would like to know if he's coming ventilated, what kind of FiO2 is having in ICU, what were
Okay,
the ventilatory settings? Was he on any sort of cardiac support?
okay. Hemodynamic stability.
Sir,
What will be the
sir,
problem if the patient is on high FiO2? In addition to FiO2 and hemodynamic, one more important thing which will be there in if patient is on high ventilator setting. What
sir,
is
what
that?
kind of PEEP is he having?
Okay. So because the even if, during the transfer, even you are receiving the patient, this will be a problem. If it is patient is requiring high FiO2 and high PEEP, that will be a problem. Okay, that will be a challenging scenario for you. So as
Sir,
like what you are telling, the only that you will be evaluating the patient when it was positive, how is the overall condition of the patient, and then what else you would like to do?
sir, I will see the current status, whether he is COVID positive currently, and I will risk stratify him on the basis of his HRCT finding. I will look for uh, presence of opacities in how much loads.
Actually, you are now overdoing it. Okay. You are
Sir,
repeating. In evaluation, the status, the word is finished. There are so many things you need to tell about it. So
sir, nextly I will prepare my OT. I
so
will be ready
occupational,
for
like you will be announcing, like this will be occupation hazard. Okay. So in the OR, you will be announcing. So you will be ready for uh, you will announce and you will be ready. So how will you take care? What precautions you will do?
sir. I will minimize the staff to that OT. I'll
Okay.
make sure that all the only relative persons, only relative staff is there, and they are wearing PPE.
PPE. Okay. So like what different like if it's a bearded person, so what they will be using?
Sir, N95 mask.
Will N95 mask cover in the beard patient? Beard doctor?
Sir, I didn't get the question.
Like for example, if the patient is sorry, if the doctor who is providing the anesthesia care is bearded. Okay.
Uh,
So what they
Sir,
will be
wearing of
using?
face shield. Face shield.
Face shield with what about pepper?
Sir, never heard about it.
Pepper, the machine which is providing the fresh oxygen. Has anyone got huh? This purified air? You see, I forgot the abbreviation. So you just check it about it. Some details about it. Because now COVID era is gone, but still they can ask you a COVID patient coming for OR. Okay, N95 or shield. And this is there, but actually for beard doctors, the patient who are dealing taking care of airway, they are supposed to wear pepper. Okay, maybe I'm not writing the correct pronunciation, so you can just have a look at it. Okay, purified, yes, powered air purifying air, very good. Okay, so that is pepper. So actually the mechanism is that it takes the air from outside, freshen it and give it to you. Okay, it's a battery operated. You see, if you remember the devices which they used to wear, it was a horrible time. I also worn some few times. So this will be one thing. Rest of the things you are telling rightly, face shield,
Sir,
N95 mask, and minimize the airway manipulation. Using of, if you have, of course, this patient in this scenario, patient is already ventilated. But if you need to intubate, you better use video laryngoscope. Okay.
yes, sir. And sir, secondly, if he's coming for gastrostomy and if he's not ventilated, I would like to do it in regional or discuss with the surgeon so that minimum airway manipulation is taking place.
Gastrostomy is very difficult to do in regional. Okay. Because a number of time now they are doing it laparoscopically. So it will be difficult. It will be difficult with regional. Yes, wherever possible, COVID patient for any procedure, if it is like possible to do it in regional, that's preferable. Okay.
Right.
So actually, they can ask you any patient with any infectious disease. Okay. Any infectious disease, it may be like airborne or it may be IV, like HIV patient, the or any like this MRSA positive, okay, or any communicable disease which in which you need to take care. So universal, you can say universal precautions and something extra. Okay. In addition to universal precautions, you will say something extra. So you are using gloves, you are using like shields, and you are properly sterilizing yourself. Okay. Yes. Yes, you want to say something? Okay. So they can ask you this question. Okay,
Sir,
Talha is here.
Sheriar is another exam candidate. Sheriar.
Okay. So let's Shahriyar, you.
जी अस्सलाम वालेकुम सर.
Walaikum assalam. Okay. So how you calculate nutrition requirement in ICU?
सर
Yes,
मेरे से ही सवाल किए.
yes, and I'm talking to you.
सर सबसे पहले टोटल एनर्जी
Actually,
रिक्वायरमेंट
I'm sorry,
कैलकुलेट किया जाता है.
Shahriyar, sorry to interrupt. There are some people who cannot understand our language, so please speak in English.
So first thing is we calculate total energy requirement of the patient,
Okay,
which is calculated as 25 to 30 kilocalorie per kg per day.
okay.
So then we have to calculate the amount of protein that we have to give, the amount of carbohydrates and the lipids. So
Okay,
protein is
so
given as
yes, please continue.
the protein is given as 1.1 to 1.5 gram per kg per day.
Okay, so you are missing something. Usually we spare protein for the caloric count. Okay, protein is for usually I know when we are counting the calculating the fluid requirement and everything, but usually you spare protein for positive nitrogen balance. Okay, okay. So in normal usually it's caloric requirement you try to fulfill with carbohydrate and fat. Okay. Yes, continue, please.
So once we've calculated the protein requirement, then we take out the amount of fats that we can give, which is 40%. I
Okay.
guess 40% of the total
In
energy has to be given
which
with fat.
patients you would like to have reduced carbohydrate and more fat?
Sir, I'm sorry, मुझे नहीं पता.
Which patients tend to produce CO2 more or retain CO2 more? Patients with COPD. Okay.
Patients with the respiratory failure or COPD,
Yes,
yes.
respiratory failure or COPD, like for example. And which patients you would like to reduce protein?
Patients with the chronic kidney disease.
Okay, so renal patients. So okay, so you will calculate the calories, you will calculate divide it. So usually how much in input of from fat, protein and carbohydrate, like per how much per gram, how much energies you got?
So fats give around 9 kilocalories per gram,
Okay, good.
and protein give around 5 kilocalories, 4 to 5 kilocalories per gram.
Okay, I actually this I forgot. So Hassam, you can correct. I think for carbohydrate it is 4.
Sir, both for
Anyone?
proteins and carbs, it's 4 kilocalories,
Yes.
and
Okay, so
for lipids, fats, it's 9, as Sharia told.
okay. Okay, so this is one thing. So, like, for example, how would like if you I say that you have to give like it's 5 kcal per gram. Okay, so how will you calculate how many mils you need to give for carbohydrate or fat, or how you calculate? What are the common preparations which you use?
So normally, Joe, the preparations that we can give, they come in polymeric uh, preparations. These preparations normally have almost 1 kilocalorie per
No, that
ml of
that is
the
fine.
diet.
That is, I know that usually they combine it, but to just to
Mhm.
understand, if you want to prepare yourself, because a few years ago there was no preparation, like nobody gives like now like that. In good hospitals, it's coming in like like a bag, whether it is TPN or whether it is enteral rotation. But in those both forms, it is coming as a preparation. But just to make an understanding, how you prepare yourself. Like for example, carbohydrate, which preparation would you like to give? It's actually it's 25 or 50% or even 10% according to the volume required. Okay, so 10% will have 100 milligram per ml. Okay, so that's how you will calculate. If it is 25%, is 250 milligram per ml. That's how you will calculate. Similarly, I think, if I'm not wrong, this lipid proper usually they are 10 or 20%. So say, the same rule will be applying here.
Sir, it is
Hassan?
generally 20% lipofundin, and for dextrose we use 5% dextrose, 10% dextrose, and for protein we use 5% amino oil.
Mhm. So that's how
But
actually they do, this question can come in a talks as well. Okay, they can ask you, they can give you a scenario, they can give you a condition, and they would like to tell, they will tell you the weight, and they say how you calculate it. So you usually it's the in the same way as Shahryar is mentioning. It's 20 to 20 30 kilocalorie per kg, and then you multiply the stress factor. Okay, you add on the stress factor, then you calculate, divide it into protein. Usually you keep protein caloric, you don't count it. So that's for nitrogen, positive nitrogen balance. Okay, and for then carbohydrate and fat. Okay, and then you add on the other essential amino acids and vitamins and other things. Okay, so that's how they usually you should be like knowing. Okay, so okay, so like if I ask you, what are the hazards associated with TPN? Yes, Shahryar, or anyone wants to speak out? It's like
Sir,
ju-
as for administration of TPN, we require a central venous line.
okay,
So we
only
can
CVP.
start by saying, uh, no, it cannot. Normally, the practice is we use CVP for administration of TPN.
Okay,
So we can start by mentioning hazards of uh, um, uh, by hazards of insertion of a CVP line, which include bleeding,
line related.
infection, in
Yes,
line related,
bleeding, line related infection, and actually
pneumothorax, and
this can be go through PIC line as well.
yes, sir.
Okay,
So then comes the hazards of administering TPN, which include overfeeding, um, um,
what do you mean by
sepsis.
overfeeding?
Uh, if uh, more than required amount of energy is being given, then it comes under the definition of overfeeding and it has hazards as well.
Okay, what is refeeding syndrome?
So, refeeding syndrome is a condition which happens in special certain group of patients who are starved or malnourished, and when they are introduced a feeding, such patients uh, have intracellular pump uh, deficiencies or intracellular pump disruptions, which allow a lot of electrolytes leaking from the cell into the plasma. So when feeding is introduced in such patients, insulin is released and all of the electrolytes present in plasma are shifted intracellularly and they cause depletion of electrolytes within plasma. And mainly the electrolytes deficiency that occur are hypokalemia, hypocalcemia, hypophosphatemia.
So it will present in lethargy. If the patient is awake, patient can be lethargic, patient can become apneic, there may be arrhythmias, things like that. Okay.
Yes.
So usually whenever we start feeding, usually we start gradually and we build up over 24 hours to 36 hour or two. You don't build up immediately. Okay. And similarly, if you suddenly withdraw, stop it, there may be chances of hypoglycemia. Other way around. That's what happen if a patient is coming to from ICU to OR, and and somehow you are not able to continue it in the OR. Patient can became hypoglycemic. Okay. So when you are giving it through enteral route, what can complications can occur? Dr. Aslam, you asked the question about stress factor. It is according to the stress 1.2, 1.4, 1.6, like that. So you multiply the calories from that. Okay. According to
Okay.
to the level of stress. You asked this question about. Okay. So Hassam, you or Shariar, you want to continue, please? And through enteral route, what complications can occur?
So these
Yes.
can be related to nasogastric or whatever the route that whatever the tube that we are using.
Mhm.
If it is dislodged or misplaced, so the dislodgement of dislodgement or misplacement of the tube can cause complications. Um, if you're feeding in supine position, then that can cause aspiration risks. Uh,
Okay. What else? Aspiration,
Regurgitation.
VAP. Okay. What else? What about diarrhea? Can it cause diarrhea? Yes, diarrhea.
Not sure sir, मुझे यहाँ याद नहीं है.
Like
Maybe
actually, it's
again,
a
if you have read somewhere, please.
sort of irritant. Okay, so it can cause like
Yeah.
that.
Mhm.
So these are the question calculation. What is the this is the rough method. What is they can ask you to write this Harris Benedict equation. You should be know you should cram it, I think. Okay. Then they can ask you the other way is the calorimetry. Okay. The exact method to calculate the caloric requirement is through calorimetry, and that's it. These are the common questions they can ask you from nutrition. Okay. Okay. So now who want to answer? Assam, you want to answer, or
Sir,
Dr.
Dr. Zishan is also another candidate. You can also
Okay,
involve him.
so Dr. Zishan, which with which
Yes,
name?
sir.
Yes. Okay. So just a second. What is brain death?
Sir, sir, brain death is a state in which there is a in which the functioning of the brain stop, which can cause a cessation of the breathing and basically which cause cessation of the breathing, sir. Matlab, there is no absent breathing.
Only absent breathing is brain death. There is a specific definition for it. Anyone else can speak out for that? Actually, there are two things. One is breathing, and what is the other thing?
Loss of
Conscious
consciousness.
Loss of
consciousness.
consciousness.
Okay. And
Brain death.
what is preconditioning for brain death? Like when, for example, if patient is given muscle relaxant, patient will not breathe. If you have given a lot of sedatives, patient will not have consciousness. So will you say it as brain death? No. Okay. So what will be the preconditioning?
Sir, preconditioning are before declaring brain death, the following preconditions should be met. The exact cause of the etiology of brain death should be known, and few causes should be ruled out, which includes absence of muscle relaxants and absence of sedation. Patient should not be on any muscle relaxant or sedation. The following drugs should be ruled out. Then few of the states should be carried out. The patient should not be hypothermic, and the electrolytes should be within the near normal range, and the patient should be on mechanical ventilator and should be on mechanical ventilator, sir.
Okay.
All
Anything
the
else?
and all the other reversible causes of all the reversible causes should be corrected before starting the brainstem testing. So all the reversible causes should be corrected, such as electrolytes, acid-base balance, all the endocrine abnormalities, and these should be corrected before initiating the brainstem testings. And the blood levels should be checked to rule out any presence of any sedative or relaxant drugs. So the level should be clear of those drugs too, sir.
You will also see whether the muscle relaxant effect is finished. Okay.
Yes, sir.
Okay. So how will you do the brain death testing?
Sir, initially, sir, there should be two doctor present, and one should be both should have experience of more than 5 years, sir. And when the test is carried out, so the first test which is carried out, and if the patient is declared dead, that should be the time of the death. So in the test, sir, we start by examination of all the not all the cranial nerves which could be tested. So we start by starting the pupils. We check first. We check the pupil size, and we see the reflex if that is present or not. We use it with the light, and then that is pupil reflex. And then after that, we check for the corneal reflex. We touch the white sclera of the eye, avoiding damage to the cornea. After that, there is caloric testings, which include vestibulo-ocular reflex, which rule out that. Then we can apply pain to the patient, supraorbital pain, to rule out for other tests. And then we check gag reflex and cuff reflex. And after that, if all the tests are negative, then we go for apnea test, in which the patient is first pre-oxygenated, and then after pre-oxygenation, patient is disconnected from the vent, and pre-op ABGs and post-op ABGs are compared for pre-CO2 level to see if the patient has started his own breathing or not. And if the patient has not started his breathing after raise of PCO2 of more than, I think, 6.6, then the patient is declared brain dead.
Okay. Okay. Anything you miss? one very small point. You said two doctors, so it is at two, not necessarily two doctors. It's to be done at two specific times. And you said 5 years. No need to. Again, I tell you something, because it's different in different countries. Okay, so according to
Okay, sir.
the like whosoever is eligible to do the testing in that country, you will follow that rule. And usually at two different like there should be some gap between two different examinations. I'm not sure whether two doctors are required. It's two different times which are required, if I'm not wrong. Yeah, you can just correct me, because I have read many years ago. I still don't I don't remember exactly. Okay, so in what I remember, it's two different times. Okay, and
Yes, sir.
okay, so what are the possible outcome for brain death patient? Like what next can be, what will be the fate for that patient? What things
Sir,
will
either
be?
we, sir, we should after the patient is declared brain dead, so we can if the we can ask about the patient consents or the patient attend consent regarding the organ donation, if they are willing for uh, donation of required organs, which could be uh, beneficial, which could be done, sir.
What about DNR?
Yes, sir. DNR do not resuscitate if the
So it
patient
is
is
it is also related to
declared
brain death. If the patient is brain
yes, sir.
dead, you sometimes you are labeling it as DNR. Am I right? So DNR is a
Yes,
concern.
sir.
Family, you ethical issues. You have to respect the not only the religious considerations, and like, so these are ethical issues you need to consider. Okay, and then you need to consult the patient family about it. So these are the things they can ask you uh, this question, because this question was similar in this way. I was asked to me in Irish fellowship exam. That there was an accident outside. From there, they took for the CPR, few words they asked, and then they took the patient to ICU, and then they took asked me about how will you prepare the patient for organ donation. Okay, so related to organ donation, what would you be doing? What are important factors from your side?
Sir, first of all, the ethics should be followed while proceeding for organ donation, and the patient attendant should be counseled, uh, and the status of the organ donation should be known regarding
Mhm,
from the close relative. And after
mhm.
the consent has been taken, so uh, we should try to maintain the hemodynamics of the patient so that the organ perfusion could be maintained and uh, till the time of organ donation, sir. So we should keep the patient normotensive and rule out any contraindications regarding the patient which could make the patient ineligible for organ donation, sir.
Okay, so usually which what are the goals when you are doing this? There are certain things we need to maintain. How much should be the blood pressure? How much should be? Would you like to give? Are there some medications which the patient receive?
Yes, sir. Usually the patient are on vasopressin and I think T3 thyroxine, sir. These two medications usually patients are on, sir.
Yes, Sam, just because I don't remember exactly. I read many years, but you should be knowing which, there are certain, if I'm not wrong, there are certain parameters you need to follow. Okay. And then, uh, uh, you, as mentioned, I think steroid, vasopressin, and T3.
Yes, sir. These three. And sir, targets are we should keep the map between 60 and 80. We should keep the ABGs with PO2 and PCO2. We should try to keep the PCO2 between 35 to 40. We should keep maintain a urine output, sir, of approximately 1 to 1.5 ml per kg. And then comes the vent setting. So we should try to maintain a proper peak pressure. We should not let the peak pressure be raised for more than 30. And we should avoid hypothermia, sir. These are the targets, sir. Basically, targets we should
Yes, also
keep.
temperature, also like maybe you need to control you need to give insulin to control the blood sugar,
Yes, sir.
and you have to maintain the urine output. These are the things we need to. I just opened, actually, I found it, I just searched. So as I told you, methylprednisolone, insulin, vasopressin, maybe desmopressin. Okay. So okay, so I think that's enough for today. I try to cover some of the topics. I send a list of the topics because like remember one thing, like in our previous session, we just try to cover the basic concepts, and like because they can ask you any question like sepsis, ARDS, VAP, and there is some basic things which you have to remember. Okay, and after that, specific questions they can ask you about, but there are certain things which are most important, which are common. Okay, so I think okay, just a second, please. So we will continue our. So thank you very much. So